This is Heart Rhythm TV. I am Roderick Tung. I'm joined by Timothy Markman from the HUP, the Hospital University of Pennsylvania. Welcome, Tim.
Thank you very much. Great to see you.
And we're here to discuss your featured Heart Rhythm Journal article, Pectoral Nerve Blocks for Implants, something that I know nothing about, which is why we thought the viewers would love this, because it's novel.
Yeah.
Tell us a little bit about why you started looking into alternative ways of local anesthesia and deeper anesthesia.
Great, terrific. So there's two associated and somewhat competing goals of the research. We want to reduce post-operative pain for device procedures, and we also want to minimize opioid use. And those two things are somewhat competing, and you can do that simply by not prescribing opioids, but then you have more pain. Or you can do what surgical fields have done, which is use multimodal approaches to pain, like regional anesthesia, and PEC blocks are a really good way to do that.
So this is something that you really fell in love with and said, let's try to roll this out at 7 centers within your system.
Yeah.
And when I first saw this, I was like, oh, this will be cool. It'd be like 5 cases, 10 cases, something novel, but it's over 600.
Yeah.
So basically, most people bought into this, or many people bought into this and said, all right, let's just start doing this routinely.
It's very easy to do, and that's really what it comes down to. So nerve blocks can be really complicated. It's a whole field of anesthesia. Pectoral nerve blocks are sort of an exception. It's very easy. You do not need to identify a nerve. You identify a fascial plane. And for those who do ultrasound for their vascular access with devices, it's really very easy. It's anatomy that you're already familiar with if you're using ultrasound, and there's not a big step from the access you're getting to also doing a nerve block.
So you are, and I love this because this is more of the hands-on part, is you are using intra-pocket intravascular ultrasound for all of your axillary sticks?
Correct, yeah.
Okay.
Yeah, exactly. And the way that anesthesiologists do this procedure is percutaneous, so it can be done percutaneous through the skin, but there's that much extra tissue, and it's that much harder. But our standard approach, or my standard approach, and all the operators who are in the procedure is intra-pocket axillary access with ultrasound guidance. And with that ultrasound positioned in that same position, it's a slight angulation and translation caudally, and you have the perfect view for a pectoral nerve block.
Great. And so then for your access, you're not using any fluoroscopy at all?
Rarely, yeah.
Except for to see the wire go down.
Right, exactly.
But your puncture is completely there.
Ultrasound.
That's fantastic to hear that. How many cc's are we talking? Not so the little tips and tricks?
Yeah, so this procedure is you're identifying a plane, a fascial plane. When you inject the local, the fascial plane spreads, and then you're bathing that plane. So you need to give enough volume to sort of fill that plane. Sure. So if you do a very small amount, you don't want a very small amount of very concentrated local, you want a volume to fill it. So in the study, to standardize it, we did 15 cc's.
Okay.
But there's some give or take, but you don't want to do a really small amount.
It's not crazy amounts.
No.
Yeah. And then you start looking as your main outcome as just post-operative pain.
Yeah.
Right? And that's going to be, are you guys, first of all, doing some same-day discharges?
Almost all were same-day discharges.
And there's a recent Heart Rhythm consensus on same-day discharge for AFib and ablations, and there's a big statement that came out at this meeting.
Yeah.
So you're doing almost all, so that does matter, the opiate usage, right? So we're trying to set the stage of why that could delay discharge, increase length of stay, right? And convert it to an observation that you don't need.
Yeah.
So what did you find?
So pain scores went down. So standard pain score, 10-point scale. Pain scores were lower with a PEC block than if you didn't do a PEC block and you just had subcutaneous local. About 3 points lower, which is significant in the context of, or substantial, I would say, in the context of a very easy, very low cost, very simple procedure. The dramatic finding for me, the most important finding, is that in the control group, the standard group, about a quarter of the patients at some point had severe pain, so greater than 8 out of 10 pain. And I think EPs consistently underestimate the amount of pain that our procedures cause. So at some point, nearly a quarter of the patients in the standard arm had severe pain. In the PEC block, it was 5%. So you're taking a significant chunk of patients and making them not have severe pain.
Well, it's always fascinating to me why they don't have more pain.
Yeah.
In terms of what we do, even the skin incision itself.
Yeah.
Well, I think this is fantastic. What's the future direction now? Is this like, okay, everyone at UPenn's now adopting this? Where do we go from here?
I think it should be the standard of care. If you're doing ultrasound already, this isn't a randomized study, and that's a short shortcoming, a limitation, but the intervention
I'm sure you're
is so
planning
easy.
one.
Yeah, right. So
Okay.
our plan is a randomized study of multiple different multimodal strategies, so to figure out what is really the best approach. But today, if you're using ultrasound, it is a very short step to add this to your workflow and make a small improvement in patients' post-operative experience.
I love it because obviously conduction system pacing is so hot. Farapulse and a lot of the new technologies we're seeing, Volt come out, Affera, all these new, modalities in terms of pulse field, and what we're seeing is a return to some of the basics of how to do procedures.
Yeah.
And I think that stellate blocks are really in for VTVF, but none of us really do our own stellate blocks. We always call the anesthesiologists. So it's really important for us to, I think, get facile and agile with some of these that can really improve patient experience.
Absolutely.
Do you think this is the way? We have an ASC that's opening up next month. First U.S. academic ASC, which is what we're really excited
Terrific.
about. Is that something that could obviate the need for an anesthesiologist? Could it be that powerful, or do we think it's still an adjunct?
I think, we're using it as an adjunct. There are case reports out there of people doing it as instead of anesthesia. I think it's going to be maybe that plus a little bit of sedation that EP provides is very realistic. I mean, it can provide a lot of pain control. So that's a promising approach to potentially do some of these procedures without anesthesia and without sedation.
No, I think that's really exciting because obviously I've been at multiple institutions and some people still use, I've even seen general anesthesia used for people devices.
Yeah.
Then you see some conscious, then you see mostly local.
Yeah.
And there's so much heterogeneity in there, and I think understanding the right choice of anesthetics is critical, even with VT.
Yeah.
Are you guys doing the VTs with conscious, or are you doing with that? There's a lot of debate.
Yeah.
So this is really relevant because we're a procedural field.
Yeah.
Tim, congratulations
Thank you
on this
very much.
paper. Pectoral nerve blocks come into a center near you,
Yeah,
right?
absolutely.
And we're looking forward to the RCT.
Yeah, absolutely.
Excellent, thank you.
Thank you very much, Rod.